perspiration as well as back pain.
Do you see that there is much of variation between all the Western data, whatever you're getting
Yes,
in data?
Yes, sir.
You think there's osteoporosis?
Osteoporosis also plays a very vital role in the parameters, especially in thoracic kyphosis. That is why in elderly patients, because of osteoporosis and bed collapse of the bones, we have a positive SVA and increased kyphosis. So as a result of increased kyphosis, the losses also increases. And to maintain that, the sacral slope changes, and that's how we maintain balance.
Thank you. Thank you.
There are no more questions. We'll go on to the next speaker. Dr. Ramesh Kumar.
Good afternoon to all of you. Greetings from Ganga Hospital. I am here presenting the role of biochemical markers, serum lactate and interleukin-6 in open injuries and the timing of reconstruction. In the era of functional restoration in massive open injuries, the known facts are the resuscitation, the skill of the teamwork involved in the management, the role of antibiotics, and the reconstruction pathway where it leads to an uneven outcome, and the role of rehabilitation has been very well studied. But we need to know all in injuries is the timing of reconstruction in massive problems. The macroscopic vision of all these injuries has been advanced, and now we are looking into the molecular level where the metabolic and immune response in this aspect will carry a role in the future. Hence, these biochemical markers needs to be also analyzed along these injuries. We have studied the open lower limb injuries in September to December 2011. We have received 123 patients, and the deep infection rate in these injuries is 12.6%. And among this, 68% had an elevated serum lactate on arrival. And even after when we serially measured 23% of patients had an elevated serum lactate in 48 hours, when we analyze our deep infection rate, the flap failure, the disease out of 33 patients had an elevated serum lactate on arrival under 48 hours. When we analyze our deep infection rate, this is an example of a patient who underwent a debridement and a free flap cover, and the flap was failed with necrosis. When we analyze the serum lactate level found to be elevated even at 48 hours. When we analyze our deep infection rate, the flap failure, there is a threefold increase in the incidence of deep infection and flap failure if the biochemical markers like serum lactate is elevated at 48 hours. And there is a direct correlation of elevated serum lactate levels has been studied by many authors in multiple injuries and lead on to a multi-organ dysfunction syndrome. And there is a direct measure of occult hypertension has been studied. And there is another, the marker interleukin-6. There is direct evidence with the injury and severity of injuries being more has been studied by many authors. And the reliable markers in all these injuries where the metabolic response of the patient is the serum lactate and the immune response, the interleukin-6, is a reliable index of magnitude of systemic inflammation in all these injuries. The serum lactate, the normal value is 0.5 to 2.2 millimoles per liter. It is measured by enzymatic determination with colorimetric method. We serially measured on arrival 6, 12, 24 and 48 hours. And the interleukin-6, the titrated value for trauma is 200 picogram per ml, and it is measured by ELISA and serially measured 6, 12, 24 and 48 hours. It normally following any injury, it peaks during the first day and declines after 24 hours. The role of these reliable markers were done in polytrauma and patient systemic injuries. There is no literature evidence on isolated severe open injuries studied so far. Hence, we found our aim of the study with the biochemical markers in decision making for early intervention, the serum lactate interleukin-6 based on our Ganga Hospital open injury severity score. Inclusion criteria were all open injuries or low limbs are included with a Ganga Hospital open injury severity score of more than 10. And excluded are the epilateral foot and ankle injuries which were pregnant and uncontrolled diabetic with a glycosylated hemoglobin of more than 10, on-arrival nutrition sugar of more than 300, and patients that are having a formal injury and also vascular injuries. On arrival, all patients are evaluated as per ADLS protocol, and blood samples were withdrawn for serum lactate and interleukin-6 on arrival 6, 12, 24 and 48 hours, and injuries are measured and assessed as per Ganga Hospital open injury severity score. 97 patients were analyzed in our data, and one patient had a formal injury and 4 were found to be uncontrolled diabetic excluded. In the 92 patients were analyzed. Among these 92 patients, but the normal biochemical markers on arrival on this 49 patients underwent a single stage reconstruction, and 43 patients were planned for a stage reconstruction because of massive injury. In the single stage reconstruction, among these 49, 29 were nailing was done, and 12 were fixed with an external fixator, and 8 required a primary plating. In the soft tissue management, 37 wounds were primarily closed, and 5 required a skin graft, and 7 required a local flap cover. This is an example of a patient with an open proximal tibial fracture underwent debridement, primary plating, and soft tissue cover went on for an uneven full healing. And in the stage reconstruction, among these 43, 16 required nailing, 18 required fixator, and 6 required plating. 3 with the bone loss required an LRS pathway for a reconstruction. Among these, 9 required skin grafting, 28 were local flux, and 6 required a major soft tissue cover for the bone for soft tissue loss. This is an example of a stage reconstruction. Required a stage procedure in the form of free flap and LRS for plating and bone grafting at the docking site for an uneven filling at the end of 1 year. In this group, in a single stage reconstruction of 43 patients, you can see the serum lactate and interleukin rings both were below the baseline values. Even following single stage reconstruction, they found within the baseline values and come to the normal baseline value and maintain the baseline level even at 48 hours measurement. And it's in the picture of the stage reconstruction where on arrival you see both the serum lactate and interleukin 6 were above the threshold level. Hence, we plan for all these patients the stage reconstruction, the damage control orthopedics using an external fixator and debridement as the main procedure. And following this massive injury, the serum biochemical markers come to the normal value within 12 hours, and when planned for second surgery also they remain within the baseline value at 48 hours. We have analyzed the research in incidents of deep infection, flap failure rate, and secondary amputations. And in single study context, among this 49, one patient had deep infection and one had a local flap failure, and there is no secondary amputation in this group. In the stage reconstruction, among these 43 patients, deep infection were in one, a free flap failure in one, and one patient landed up in secondary amputation. This is an example of a patient who underwent a free flap cover with deep infection, like a flap necrosis, landed up in below the secondary amputation at the end of 6 months. And when we analyze our outcome, the biochemical marker base, among these 92 patients, we have deep infection rate of 5.4% with a 2 flap failure and 1 second amputation. When we analyze our previous study without biochemical markers, we have done 126 patients. Among these, our deep infection rate was 12.6% with a flap failure rate of 6 and a second amputation of 4. This found as a statistically significant p-value. Hence, to conclude, there is a proportionate increase in both serum lactate and interleukin 6 even isolated open injuries or lower limbs. Serum lactate and interleukin levels increases the severity of injury, and these biochemical markers can be used as a tool for reconstruction based on our open injury severity score. Thanks for your attention.
These two chemical level, what you told us, do you think that when it is high, this reconstructive surgery should not be done?
Yeah.
We have to wait till it comes down.
Till it comes down.
What is the average time to come down?
I wish.
We don't have a system to measure it. On average, time should be given when they come back after 2 days or 3 days or 4 days.
Usually, it comes within 48 hours.
Immediate surgery is not required.
Immediate surgery is the form of debridement and a fixator may be required. But the ultimate definitive treatment has to be you're planning at the end of we measure the biochemical. If they come to the baseline value, you can go ahead with the definitive management.
So again, after 48 days, you should go for measurement. If it does
Yeah.
not come down, it's still deferral.
Yeah. This addresses both metabolic activity of the patient and the immune response. The immune response, if it is an immunocombat, it takes a little longer time, but the metabolic response, serum lactate, if it comes down, you can go ahead with surgery. Otherwise, the chances of infection is high.
What is the reason behind it?
You see, all these injuries needs a metabolic level of oxygen. You see, all these patients who develop massive injury develop a metabolic anaerobic oxidation. They form a lot of thing. So the oxygenation to the particular tissues are delayed. So if you don't have the chances of perfusion, the chances of flap survival, the chance of
In case of simple injury, that is not compound. Again, if you wait for 48 hours, you do it.
by the levels are normal, you can go ahead.
You don't have a measure to find out even. Only simple injury can give you high level of only compound gives you high level of lactate.
Compound major injuries give a high level of lactate.
Simple injury doesn't.
Simple, we are measured in simple. That's what single stage reconstruction always simple injuries, so that you can do a definitive management at the index procedure itself.
Suppose there is a compound fracture and we have got a numb injury also, vascular injury also, then you can't wait for 48 hours. Do you think that means it is predestined to develop complication?
This concept of definitive management is indicated only in patients who had other injuries. If it is a vascular injury, there is because this study doesn't involve vascular injury, because the vascularity alters the biochemical marker. The study was done only in patients with intact neurovascular structure. We are focused mainly on grade 3B injuries. I mean, for the biochemical marks mainly are damage control orthopedics.
Any more question?
Any treatment for this? something like some medication, some cancer drug, something to be given to patient.
Yeah, there is only fluid, there is normal saline. Normal saline. There are, this is a good hydration. Yeah, good hydration will wash away all the aerobic products. It's the only thing, if the patient is an hypovolemic, you need to give a blood and crystallines.
Okay, thank you. Now we will call upon the next speaker, Dr. Ramesh. Ramesh, Dr. Rishi Khanna.
Good morning, everybody. My presentation is on the genetic susceptibility of lumbar degenerative disc disease in young adults. It is an association analysis of 35 genes based on total degenerative disc score. So we know low pain is an important public health, social and economic problem with a lifetime prevalence of 80%. And the back pain related economic loss is quite huge. And it is the second commonest reason for this work. If you look at the basic pathology of patients with low back pain, degenerative disc disease is an important etiology. And if we look at the etiology of DDD, it seems to be multifactorial with many factors like genetic predisposition, mechanical overloading, repetitive trauma, smoking, aging, and vascular reasons have all been important factors in the initiation of DDD. The literature is replete with a lot of evidences to support both environmental and genetic factors in the initiation of disc degeneration. This all started with the STIM study in the late 1990s, where they found in 300 monozygotic and dizygotic twins, 60% of the influence of disc degeneration was genetic. So how do genes affect disc degeneration? If we consider all types of genetic abnormalities, chromosomal abnormalities and mutations are the severest and lethal forms of genetic damage, whereas single nucleotide polymorphisms are much more common and they are likely to be involved in the initiation of disc degeneration. So what are the single nucleotide polymorphisms? They are also called as SNPs or SNPs. These are DNA sequence variation occurring in a single nucleotide in the genome differs between members of the human being, and these two forms are called alleles. For example, if we consider allele 1 of a particular gene, this forms protein 1, and if there is a single nucleotide polymorphism at one of the levels, for example, thymine articulates with adenosine, and there is a single nucleotide polymorphism resulting in the formation of allele 2. The allele 2 also forms the same protein 1, but qualitatively they will not be similar. So far in literature, there have been more than 50 single nucleotide polymorphisms for disc degeneration have been identified. But what are the drawbacks in the previous studies? There have been different and non-specific phenotypes have been used, lack of definition of disc degeneration, there has been no age group stratification, and ethnic variations between the different studies. For example, if we consider the description of DDD, it differs in many studies. Patients with Schwartz nodes, Modi changes, disc prolapse, disc bulge have all been included. And in one of our earlier studies, we found that in the same study population with DDD, SNP association completely changed when different radiographic features were used to define the DDD phenotype. So phenotype definition is very important. And with aging, disc degeneration is an inevitable phenomenon. So if we include patients of all age groups, the role of wear and tear and environment can affect the outcome of the studies. So it's a very important study only young adults to understand the role of genes in disc degeneration. We considered nucleus pulposus degeneration as a phenotype, and based on prevalence grading, we selected a highly specific phenotype of severe disc degeneration in young adults. So the next question arises, what constitutes a severe disc degeneration? Is it a patient with DDD at 1 level, or DDD at 3 levels, or DDD at multiple levels? This far we developed the total degenerative disc score based on prevalence grade at each level. We calculated the prevalence grade at each level and added them together to develop the total score. And a patient with less than 10 considered a mild TES with moderate score of 10 to 15 and a serious score more than 15. Genotype selection was based on the premise that this degeneration is a multimodal pathway with genes representing the structural damage, the strength of the framework, the strength of the end plates, apoptosis, and inflammatory mediators were all considered. Totally, we had 35 genes and 58 SNPs with 11 structural genes for the matrix. So the aims of the study was the genetic association of severe DDD in young adults was studied to correlate highly specific phenotype of disc degeneration. And in the inclusion criteria, we included patients with low back pain and disc degeneration of both sexes, aged between 18 to 40 years, without no evidence of any other spinal diseases, non-smokers, no previous history of any lumbar spine surgery or significant spinal injury. After the patients were included in the study, they underwent a 1.5 MI to calculate the TDDS, and blood samples were analyzed to DNA separation and sequencing analysis were performed to study the SNP. Coming to the results, there are total 518 patients of a mean age of 28.4 years, and the patients were divided into 3 groups based on the total degenerative disc score. There was no significant difference in the population size, gender difference, and the mean age. We found that 3 genes are significantly associated with severe disc degeneration in young adults. Among the 30 target genes that were studied, including 4 new candidate genes, there was no significant association. So severe total degenerative disc score greater than 15 in young adults was significantly associated with matrix metalloproteinase 7, colmetoline, and COX2 genes. So we know that matrix metabolism is a delicate balance between synthesis and degradation. And MMP7 is an important member of a family of proteolytic enzymes that participate in the degradation of major matrix components. So during degeneration, normal matrix synthesis decreases and degradation increases. So this abnormal expression of MMP7 can lead to early disc degeneration. Colmetoline, this is the second gene that we found, is a principal mediator of calcium signals intracellularly. It has been found in previous studies to be expressed in articular cartilage and increase in osteoarthritis. And this degeneration also is characterized by disintegration, loss of cartilage and plate damage leading to DDD. And this is the first study in the literature to study the association of colmetoline 1 in lumbar disc degeneration. Cyclooxygenase 2, this is the third gene that we found, is an important enzyme responsible for formation of biological mediators. It mediates inflammation and pain, so this could be involved in DDD related to low back pain. So in summary, the matrix metabolism of the disc could be affected by abnormal metalloproteinase leading to abnormal metabolic breakdown products. This with an abnormal COX2 can lead to excessive inflammation, and with abnormal mediation of signals through colmetoline mediates matrix disintegration leading to disc degeneration and low back pain. This actually perpetuates a vicious cycle of decreased synthesis of matrix and increased degradation. The unique features of the study were this is the first genetic study of young adults with severe disc degeneration, first study to study the Indian population, and we had studied a lot of FNBs of more than 58 in 35 candidate genes with a huge study subjects. And we found that different pathways of disc degeneration is mediated by different genes. And most important feature was the selection of highly selective phenotype. By selecting young adults, we have reduced the effect of environment and wear and tear, and we have reduced the outliers by using the total degenerative disc score. So in conclusion, this is the first study in literature to analyze the genetic basis of DDD in young adults. So specific single nucleotide polymorphism of 3 genes, MMP7, colmetoline 1, and COX2 in young adults is associated with severe lumbar disc degeneration. So by studying 3 genes, we found that this degeneration is a complicated disease with an intricate interplay of multiple genetic polymorphisms. Thanks for your attention.
Any questions, please?
What you actually did in this whole work?
Selection of the study subjects and analyzing all their MRI features to develop the degenerative disc score, and the final analysis of all the study subjects were done by me.
Any further work has been done in the?
We are now recruiting a large study population to have a control group where patients who do not have low back pain and disc degeneration are also being studied to compare the results of the study.
So you have taken all these study in an age group where normally there is no disease there.
No, this is the group of patients who are less than 40 years but have developed disc degeneration at an early age. So genetics is an important reason for them to develop disc degeneration. Then these are the ideal group of patients to study.
But MRI itself, now you have come to understand gradually, MRI itself, whatever these diseases that show, that is not clinically relevant as you said itself. So should we call it a disease, or is it just we are seeing more than what we should see?
So that's why we took this total degenerative disc score, where patients who have disc degeneration in all the 5 lumbar discs. Normally, if we have a disc degeneration developing, it will be 1 or 2 levels. If somebody is developing disc degeneration in all the 5 lumbar discs, then something is abnormal in the genetic makeup, so that they are predisposed for degeneration.
Okay. Thank you, Dr. Rishikanta.
Thank you, sir.
Now we will call upon the next speaker. Azu Bosco is there? Azu Bosco is not there. Okay, Dr. Rizwan Basha.
Often chairpersons, senior colleagues, greetings from Ganga Hospital. My study is about fragility fracture risk assessment using calcaneal texture analysis. Worldwide, there are more than 8.9 million fractures occurring annually worldwide, and for every 3 seconds there is an osteoporotic fracture occurring. Not only the numbers are staggering, but the burden which it comes is dramatic. Around 50% of mortality occurs within 1 year of geriatric fractures, and the US spends about $25 million in managing these osteoporotic fractures. And the cost of management in these fractures are going to increase in the coming years. The only way to reduce this burden will be mass screening. The various modalities of mass screening we have looked at now. The current screening modalities are based on bone mineral density, which are DEXA, QCT, and ultrasound. They have limited use nowadays because of high cost, limited availability, and high radiation exposure. And bone mineral density is significant only in population studies, but very less efficient in individual studies. But the latest definition put forward by the World Health Organization says that defines osteoporosis as a disease in which the bone density and the bone quality is reduced. Hence, bone fragility is not only described by bone density but also by bone quality. The bone quality is determined by the rabicular structure, which is severely affected in osteoporosis. The various methods of assessing this rabicular structure of a bone are: the most direct way will be a bone biopsy, and the three-dimensional way will be micro-CT and MRI, and the two-dimensional way will be radiograph with texture analysis. Bone biopsy being high cost and of limited use, we cannot use bone biopsy for mass screening, whereas three-dimensional studies like micro-CT and MRI can be used for mass screening. And for a country like India with 1.26 billion population and at-risk population of 160 million, and this at-risk population is expected to grow in the coming years because the expected age of death in Indian population in the coming years will be high, so there will be more people in the voter age group which we have to cater for. And not only the numbers are high, the cost in which doing this mass screening for individuals is high. Imagine doing a CT and an MRI and DEXA for 160 million, and CT costing 3,000 or 5,000 bucks, whereas X-rays cost only 300 rupees. Not only the cost is important, the availability of this diagnostic modality also is a factor. CT and MRI and DEXA even in metropolitan cities is of limited availability, whereas digital X-rays are widely spread nowadays. And radiation, CT has 10 times more radiation than the X-rays. Hence we feel radiograph with texture analysis is a solution for mass screening of osteoporosis in India because it's widely spread, easily operable, less expensive, and less radiation. The big question is, what is texture analysis? Texture is a term used to calculate the surface of a given object or a region. In texture analysis, the basic unit is a pixel. Pixel is the smallest element in a display which carries only the intensity information. If this is an X-ray, and if we focus and we magnify, we see the pixels. Each small squares are the pixels which carry only the intensity information. This intensity is measured by the gray levels. This picture denotes different gray levels. The run length parameters are measured by a parameter called as a run. A run is a set of consecutive pixels having same gray levels in a given direction. If suppose this is a pixel with different intensities, and these intensities are given a gray levels, and these gray levels are measured as such a length. The top three columns which has several gray levels will form a single run, and any gray levels in the consecutive same will have a same run. Hence the picture will have a multiple run. Using this picture, the computer computes a two-dimensional array in which the rows will be the gray levels and the columns will be a run of the length, and will be indicated as run length HJ, H will be the direction in which the study is done. Using this two-dimensional matrix, the computer will have various descriptors from which the study can be analyzed. There have been earlier studies which have used texture analysis in radiographs to analyze osteoporosis in individuals. With this background, we did a study in which we compare run-length variables from texture analysis between fractured and non-fractured group. We also compare bone mineral density and fracture score with texture variables. In our study, we included 61 cases of osteoporotic fractures, trochanteric fractures, neck of femur fractures, and vertebral fractures, which are admitted in Ganga Hospital. And we took 31 cases of controls, which are admitted in our hospital for other causes other than fractures. All pathological fractures, pre-existing metabolic bone diseases, and patients who are taking drugs-related bone cells were excluded from the study. All patients who are included in the study underwent digitalized radiograph lateral view of calcaneum by a standardized technique, and we chose calcaneum because it reduces exposure to RBS of the body, and calcaneum is abundant trabeculous bone, and it's a weight-bearing bone. All the X-rays were digitalized using Kodak film digitalizer, and the size of the pixels were 100 micrometers, and the region of interest was selected in a standardized manner, and the region of 128 into 128 pixels was selected, and it was fed into a computer with MATLAB solver to achieve the texture variables. Along with the lateral view of the calcaneum, we also assessed bone mineral density using QCD of L1, L2, L3, and fracture score. Fracture score is the latest diagnostic tool by World Health Organization to diagnose osteoporosis. It has various demographic data to assess osteoporosis in an individual. The results: In our study, the mean age of cases was 76 years and the controls was 64 years. Due to the wide difference in the age group, we did a Pearson correlation so that age does not affect the outcome. And in our study, we found that there is no correlation between the age and the texture variables. Among the 11 texture variables, 4 had a significant p-value, and among the 4 low-level random sizes had a highest effect size, which was 0.4229. The texture value had a significant p-value. It was able to differentiate between fracture and non-fracture group. It had a positive predictive value of 68%. And t-score was also significant, which was able to differentiate the fracture and non-fracture group, and it had a positive predictive value of 72%. The crack score was also significant, and it had a positive predictive value of 81.5%. This high predictivity was due to the inclusion of demographic data and high-risk aspects that the study had. In order to remove the effect of age on fracture risk, we used general linear model analysis so that age could be used as a covariant, and in which we found that t-score lost its previous significance, whereas texture variables remain still significant. Hence, texture variables is not dependent on age, and our study was comparative with other studies which said that texture variables are not dependent on age. And in order to improve the predictivity, we combined frac score with t-score. The predictivity is 78.5%. When we combine frac score with texture variables, the predictivity was 84.8%. This is an indirect evidence that texture variables is better than t-score. And texture variables being less expensive, are widely available and not affected by age, and just as Arabic structure, we feel texture analysis better than t-score. Hence, we conclude that texture analysis either done alone or when combined with frac score is effective in differentiating fracture and non-fractured. Being cheap, less exposed to radiation, and easily accessible, can be used in development in India for screening purposes. Thank you.
Now you have taken the lateral view of the calcaneum only, isn't it?
Yes.
And how can you apply this to the neck of femur or lower end of radius? The calcaneum is normal, still you have osteoporosis in those levels.
So we are studying the trabecular structure of the calcaneum. Hence, if a person is osteoporotic, whole of the system would be osteoporotic. So
Calcaneum may be normal, but still, if you have osteoporosis in the neck of femur or the lower end of radius.
yes.
How can you correlate these two?
Our study is only about correlating calcaneum.
Any questions? Any other questions? Guardians?
So if there is no question, we can get to now the last paper. The economy.
Respected chairpersons, seniors, and dear colleagues. In this presentation, we are going to discuss the possible use of the antibiotic impregnated allogenic bone graft as a carrier of local antibiotics. As we are aware of the problem which we face in nowadays, in the primary or reconstructive region surgery, the depletion of bone healing and the infection are the major concern. In context, these often requires the bone graft and bone substitutes to fill the defect, to enhance and extend and substitute the bone for osteogenesis. For this osteogenesis, autologous bone graft is considered to be a gold standard, but due to its limited availability and dorsal mobility, the substitute has been tried. But the lack of integration, as we see in this X-ray, the calcium granules which has been used in this fracture, which remain as such for over 1 year. And the second surgery sometimes may be needed to remove these. With these limitations, the bone allograft can serve with plentiful quantity, with no morbidity, and provide the filling of the defect and structural support. Simultaneously, this can provide the osteointegration with the use of adjuvants and carrier of antibiotic to combat the infection. Bone allograft has been used for a quite long period. The science of this allograft using has been developed recently with the developing techniques of the sterilization, control of the immunogenicity, and use of the adjuvants to have the osteoinduction potential. Allogenic bone grafts are the non-viable tissue which eventually substitutes by the host tissue by creeping substitution by inflammation, vascular growth, osteoclastic resorption, and bone formation and remodeling. So the scope of the allogenic bone graft is growing, and with 1/3 of the bone graft used in developed country are of allogenic variety. So the current study uses the use of the allogenic bone graft for the bone and joint infection to combat the chronicity of the infection, osteolysis, and eradication of the infection. As we know, the surgical debridement sometimes alone is ineffective in eliminating the microcluster of the organism which survive intracellularly and may replicate, leading to the recurrence of the infection. So this condition requires the local high concentration of the antibiotic for a prolonged duration to combat the situation. The other methods, the polymethyl methylacrylate bone cement and others has been tried, but second surgery and for removal and osteointegration is questionable. So the current study uses the pre-screen process, deep-freezed, gamma-irradiated, modularized cancellous allogenic bone graft with the novel concept of the for antibiotic delivery system. So these allogenic bone graft are impregnated with suitable antibiotics, and also the adjuvants like bone graft, autogenic bone graft, and bone marrow is used for potentiating the osteoinductive potential. So patient was selected with localized controlled osteoarticular infection in which adequate surgical margin free from dead necrotic tissue is achieved after surgical debridement, and primary wound coverage can be done by suturing, direct suturing, or the flap coverage. Surgical procedure and fixation was performed wherever required. The hydrophilic antibiotic like vancomycin and others were selected according to the common organism responsible for the infection and culture sensitivity. These moslicized bone grafts were kept in 20 ml of distilled water containing the antibiotic solution for a period of 1 hour, and this autologous bone graft of the bone marrow is used as an adjuvant. This is a non-randomized pilot study, and cases are divided into the 3 groups. In one group, allogenic bone graft alone were used. In other group, autologous bone graft or the bone marrow aspirate was used as an adjuvant. Post-operatively, all patients were given usual course of systemic antibiotic for 7 days, and results were assessed in terms of infection eradication and healing of the bone. These cases were performed at the SI hospital, Delhi. This is the one case, 30-year male patient having the infected KL in situ, treated by debridement, exchange nailing with interlocking nail, and allogenic bone graft with antibiotic. This shows in this case, allogenic bone graft alone was used, which shows the gradual complete resorption of the bone graft and eradication of the infection. This is another case, 45-year male patient with infected non-union of the supracondylar, which was plated. Later on, the Elizarov fixator debridement and allogenic bone graft augmented with autograft was used. Subsequently, patient has shown the good fracture healing, osteointegration, and infection eradication. Another case, this is an 18-year male patient having the compound fracture tibial fibula. Patient was primarily treated with internal fixation and flap coverage, which fracture was primarily healed and infection was eradicated. Another case is a case of subpropenter fracture with infected nail in situ, treated with the allogenic bone graft, and gradually shows the graft resorption. Infection was controlled and fracture was partially healed. Later on, again grafting was performed with the implant removal. Overall results In the case series where allogenic bone graft alone was used, there was no osteointegration and gradually complete bone resorption was seen over the period of 16 to 20 weeks. Infection was eradicated in majority of the cases. In one case required again antibiotic graft. In the case series with autologous bone graft, good healing and partial osteointegration was seen in immediate vicinity of the host bone, with the rest of the allogenic bone graft was gradually resolved. And infection was eradicated in all the cases. Autologous bone graft, where the autologous bone marrow, where this was used as adjuvant, shows gradually improved bone quality, with allogenic bone graft was partially osteointegrated with host bone, and primary healing was achieved in 2 cases. And 2 cases shows the gradual complete resorption of the bone. Infection was eradicated in 3 out of 4 cases. However, 2 cases required for the secondary procedures. In overall results, success rate of procedure in terms of the infection eradication without requiring subsequent procedure was 50%, and overall infection eradication was achieved in 10 out of 12 cases. Osteointegration was achieved in all 4 cases in which autologous bone graft was used as a adjuvant. 3 cases required the secondary procedure and 1 required the revised fixation. The allogenic bone graft as carrier has been used in various studies, mainly experimental or animal study. There are very few studies which use it as a clinical study. In our study, cancellous graft has added advantage of such a graft getting resolved, preventing further perpetuation of infection if it is not being controlled, and the use of the adjuvant augments the healing potential of the allograft for favorable osteointegration. The extra-osseous-based allogenic bone graft eventually get resolved in all the cases in the time period of 2 to 3 months or 3 to 4 months. The 2 failure cases in this study is of established non-union might have required a larger osteogenic potential which allogenic bone graft alone may have lacked, so require subsequent procedure with change of fixation device. In summary, the antibiotic augmented allogenic bone graft appears to be a novel effective step in infection control and eradication. However, infection-related lysis as well as limited osteogenic potential of allogenic bone graft mandates augmentation with adjuvants. More study in larger case series are required for further evaluation. Thank you.
Thank you, Dr. Akwani. You have used both systemic antibiotics and then you are studying the efficacy of the antibiotic impregnated in the allograft bone graft. What was the antibiotic used systemically? What was the antibiotic used for the impregnated?
The local antibiotic mostly, as per the culture sensitivity report, mostly for steroids we use the vancomycin, and for gram-negative coverage we use the tobramycin and other antibiotic.
That is systemic antibiotic you mean?
No, this is a local antibiotic. For systemic antibiotic we use the first generation cephalosporin and amikacin.
No, your study is efficacy of antibiotic impregnated allogenic bone graft. You know, use systemic antibiotic.
Because it is in a clinical study, we cannot exclude the systemic antibiotic and compromise the patient condition just for the sake of this study. So this is a pilot study which has not been, I think, not been in a way to use this allogenic bone graft. So that's why in earlier studies also, a few studies are available for systemic coverage, we must provide some systemic antibiotic. This is just because for the eradication of infection, but the surgical site infection, these are also already there. So to combat that systemic antibiotic, I think we have had.
You claim that for 12 patients, the patient had no infection.
Yeah.
By this method. Similarly, for other infection, it is bone cement with antibiotic or antibiotic directly has been given. But this, what you result is, I think, because of the lesser number, result is quite high. Really impregnating antibiotic in the bone substitute for the giving there, that can rule out the infection or take completely cure infection or take out infection. It's a very high level.
Definitely, I think that depends on the selection of the patient which we have selected with the complete, in which coverage has been obtained and the dead necrotic tissue has already been removed. So the selection of the patient, I think, have better in high success rate in this procedure, because we are going to have a very in a safety manner, so we cannot blanketly use this in every case.
All right, your result is quite high. I think more number of patients has to be used to
Definitely.
confirm that it was really high.
Of course.
I must congratulate you and your team for conducting this study. I think in Indian context, this is a very, very important study, and the infected non-unions are quite high incidence in our practice. I have a few questions. I have been working on this subject for a few years. Number one, your technique of impregnating antibiotics to the bone. You just stated in 20 ml of saline plus antibiotics. Is that a standardized technique, or did you review in literature there was some better technique, or does it differ with the amount of bone graft, the amount of solution you use, or is there a standardization of technique of impregnating the bone graft with antibiotics? That is my question. First question. So you can answer one by one. I have got a few more.
Yeah. The 2 or 3 techniques has been described for the experimental use, using the covalent techniques and other techniques, but this is the simplest techniques which we can follow in OT premises itself.
Did it
So,
matter on the quantum of graft?
as per definitely the solution and the concentration has to be varied.
How much graft, how much solution did you use?
This I have given the one table with the,
It was not shown.
yeah.
Anyway,
Oh,
so you have
yeah, standardized technique.
Now, have you said you have augmented it with autograft in some cases. So do you put autograft in the same solution?
No.
So does that mean autograft is also impregnated with antibiotic, or autograft?
Ultimately in one, the autograft and allograft, yeah.
So is there any other technique, step forward, next step for this would be, wherever autograft is adequate, in most of the fracture cases, autograft may be adequate.
Yeah.
You have to impregnate the autograft with antibiotic. Is there a technique in your knowledge where you can impregnate autograft with the antibiotic, or is this the technique you use?
Some study has described the use of
Very
the,
little. Sterilization is not reported in literature.
Yeah.
Till a month or two.
but they have shown that there is this antibiotic doesn't affect the autologous bone graft and as well as the osteoblasts. But
Methodology of impregnating the bone graft with antibiotic. That is my question. But that methodology is still
yeah, it's still lacking.
process of,
Yeah, that's-
Second question, next question is, how long do you think the antibiotic will continue to be eluded from this antibiotic? Like from antibiotic segment, we know it is about 6 weeks. And are there any factors which can enhance the duration of elution and the quantum of elution of antibiotic from the bone graft?
definitely. There,
Are there any methods you are aware, or did you use those methods in your study?
that's why we have used the bone marrow. The bone marrow forms the clots, and these antibiotic get interact in the locally or vacuoles of the bone graft. So over the period of the time, that will increase the duration. This has been described in this has been described in literature. And secondly, we have also done this study. We have taken the piece of this bone graft mixed with the antibiotic and tested in a microbiology lab for the how long it is if it is effective. The results are not available with me just now. This is
So
just
we
going.
still don't know
Yeah,
that
definitely.
if you put the antibiotics
How
on
long?
the bone graft by the method that you have described, how long the antibiotic will be available at the local?
So I think we can stop now questions now, because what you are asking is that is a clear-cut answer what he doesn't have. So I think we can stop it there. We can go to the next paper.
Thank you very much.
That is the last paper, AGU Wasco. You are Aju Wasco or AGU Wasco? Aju. Welcome, Aju.
Not this. Only do this one. Open this one. 242. First one. Yeah. First one.
I think we are
Second one.
marking the same pattern.
Yeah. No, it's not in this. I give it now. No, that.
I think
You ask them. It is. It was
my
my
number
news
there.
there.
Good afternoon to one and all gathered here. There are various techniques for the stabilization of an unstable cervical spine. Most of these techniques depend on the integrity of the laminae or the spinous process. Whereas in scenarios like extensive post-laminectomy states and cervical trauma and tumors with massive destruction of the posterior spinal elements, these techniques of stabilization cannot be applied. Whereas the one technique which has stood the test of time is lateral mass fixation. It has a unique advantage in that lateral mass fixation does not depend on the integrity of the laminae or the spinous process. The lateral masses are unique to the anatomy of the cervical spine, and they form the keystone for posterior spinal stabilization. A knowledge of the relevant anatomy of the lateral mass is necessary to develop a safe strategy to introduce lateral mass screws. There are a multitude of studies available in the Western literature on the morphometric analysis of the lateral masses of the Western populace, whereas no morphometric study on the Indian population is available to date. We did a computed tomography based morphometric analysis on the lateral masses of the subaxial cervical spine of normal Indian population. This is the first extensive morphometric analysis of the lateral masses of the subaxial cervical spine in the Indian population. The study was done using helical thin slice 3D CT scan with multiplanar reconstruction. It is an extensive analysis of 600 lateral masses in 60 patients involving 4,800 morphometric measurements and around 7,640 CT films. This is the age and sex distribution of the population used in the study. The morphometric analysis was done using multi-slice multiplanar helical computed tomography scan with slices of 2 mm or less. Multiple measurements were made in the axial, sagittal and the coronal planes. The image analysis was done using Fluids Building's image processing and analyzing software. This is the measurement palette which we used in the study. In the axial plane, the axial anteroposterior measurement was done from the dorsal cortex of the lateral mass to the ventral cortex of the lateral mass at the center of the lateral mass. The axial lateral measurement was measured from the medial to the lateral cortex at the center of the lateral mass. In the sagittal plane, the sagittal width was measured from the dorsal cortex to the ventral cortex of the lateral mass just above the level of the pedicle at the center of the lateral mass, and the sagittal height was defined as the anatomic height at the center of the lateral mass. The sagittal diagonal measurement was done from the superior articular process to the inferior articular process, and the facet angularity was a vertex formed by two traced lines, one along the superior border of the superior articular process and the other along the anterior border of the lateral mass. The coronal height and width were measured in the coronal plane at the center of the lateral mass. Statistical analysis was performed using SPSS software. Descriptive statistical measurements were done. A student t-test was done and was considered significant at values less than 0.05. At all levels and for all measurements, male and female values were significantly different, as exemplified here by the coronal width. The axial AP measurements showed a progressive decrease from C3 to C7, whereas the axial width showed a progressive increase from C3 down to C7. The sagittal width showed no significant variations, whereas the sagittal height showed a gradual decrease from C3 to C7. The sagittal diagonal measurement showed a gradual increase from C3 down to C7. The facet angularity showed a gradual decrease from C3 to C7. The coronal width showed a progressive increase, whereas the coronal height showed a gradual decrease from C3 to C7. This was the measurement worksheet which we used in the study. Compared to Western literature, there existed significant racial differences between the Indian and the Western race. The lateral masses were wider in the Western race. The height of the lateral masses were more in the Western race, whereas the lateral masses were marginally thicker in the Indian race. The facet angulation decreased by approximately 6 degrees between each level in the Western race, whereas a 4-degree decrease was observed from C3 to C6 and a 7-degree decrease between C6 and C7 in the Indian race. We did an analysis of the known surgical techniques of lateral mass fixation as to analyze which would suit the Indian population. The principle of lateral mass screw placement is to adopt a divergent angulation in the axial plane to avoid vertebral artery injury and to choose a sagittal safety angle to avoid facetal violation and nerve root injury. We measured various sagittal safety angles, and adopting a sagittal safety angle of 15 to 20 degree and reformatting the CT images parallel to the plane of SSA, we measured the safe divergent angles and safe screw lengths of the lateral masses of the Indian population. The safe divergent angle, that is the axial trajectory to avoid vertebral artery injury, progressively increased from C3 down to C6, and the safe screw length progressively increased from C3 down to C6, and the safe screw length showed a gradual decrease down the C3 to C6. A knowledge of the relevant anatomy and morphometry is necessary to ensure safe placement of screws into the lateral masses. The morphometry of the Indian race is not the same as that of the Western race. These morphologic differences have implications for placing lateral mass screws safely and effectively. Until recently, no studies have attempted to directly reconcile these differences with an analysis of known surgical techniques to necessitate any modifications to suit the Indian population. To our knowledge, this is the most extensive anatomic evaluation of the lateral masses of the subaxial cervical spine in the Indian population. Our morphometry analysis showed significant size differences consisting of the findings of Abdullah et al. Significant variations existed as compared to the Western race. All values were larger in the Western race except for the sagittal thickness, which was more in the Indian race. The facet angularity of the Indian race showed a 4-degree decrease from C3 to C6, whereas a 6-degree decrease was observed in the Western race, and a 7-degree decrease was observed between C6 and C7. The morphology of the C7 lateral mass reveals that the C7 lateral mass thinks of caudally. The conventional entry point may lead to violation of the C7 T1 facet joint, inferior articular process fracture, inadequate purchase, and potentially to intrusion into the C7 T1 foramen. Therefore, we advise a pedicle screw at the C7 level alone.
Our study defines that the safe divergent angles for each level of the subaxial cervical spine. Safe divergent angles are different for each level of the subaxial cervical spine. Hence, it is not advisable to adopt a fixed SDA for all levels of subaxial cervical spine. We should plan trajectories for each level with pre-op CT and insert screws accordingly. To conclude, though our study population is large, it may not be representative of the entire Indian population. Yet, this study accurately reports the anatomy of the lower cervical spine and its distinctive variations relative to the other subaxial cervical vertebrae. It has also revealed important morphometric differences which aid in planning safe screw placements into the lateral muscles. Thank you.
The paper is open for discussion.
In fact, in which area which movement is more in cervical space, especially from C5, C6, C7?
Which movement, sir?
Yes.
Flexion extension.
No, flexion at subtle level, extension at subtle level.
Yes, sir.
The opposite direction of this trauma will cause fatality.
Okay, sir.
Because flexion occurs at the lower level, C7,
Yes, sir.
C6.
Yes, sir.
C5, C6 will be more extension.
More extension.
Thank you.
What clinical significance you can now give to your work that this work will be more beneficial? Why are you going to use it?
Sir, actually we are, for lateral mass fixation, we are conventionally using sizes of screws 12 to 16 mm, sir, length of the screw. And mostly we use 14 mm or 16 mm screws. But the thing is, 16 mm screws are too long. So, 14 mm screws are sufficient to the Indian population, sir. And after doing a study, we have started a study measuring CT of screws which we have already put in the lateral masses. We feel that the screws above the cortex, the ventral cortex, more than expected. And if it is directed in the direction of the foramen transversus, it can injure the vertebral artery. And one more thing is that known surgical techniques describe a sagittal angle which doesn't suit the Indian population. Actually, a sagittal angle of 15 to 20 degrees enough, but the techniques describe an angle of 30 degrees or 35 degrees in the sagittal plane. So we have found that the angle between 15 to 20 degrees more suitable for Indian population, and shorter screw lengths are enough to achieve good fixation of lateral masses.
Thank you. Any more question, or we come to conclusion of this whole this important section of the middle? I think all the competitors who have been here, they've tried their best to use it. And I'm happy that everyone could answer most of the questions. Good luck to everybody. Thank you. That comes to the end of it.
Thank you.